Hi, everybody. Welcome to another session of BlockHeads. We are here with Dr. Richard Slama of Riverside Regional, who's here to discuss his regional anesthesia service that he actually made financially viable. And so many of us are in a situation where our anesthesia colleagues are either unable to or just financially can't make it work to come down and do services either in the ER or even on the floors. And yet, Richard was able to figure out a way to make this happen from the ER side. So the article is in the chat and is with the email. I'm going to have him take things over. Richard, thank you so much for joining us.
Hey, thanks everybody for having me. This is a true pleasure. So again, Rich Slama, I'm the director of this regional anesthesia service line, as well as the fellowship director and also a core faculty member of the residency. Note that I did not call this APS, and there's various reasons behind that, but I think that we all have to honor that we're not the first ones who ever did this, and we should be working with our anesthesia colleagues and not against them. And so I didn't think it was right to call it APS. So yes, y'all of you probably think I'm slightly nuts. That's okay. And I think the reason was when doing this is that we all know that probably sometime 5 or 10 years down the line, we're going to really be looking back retrospectively and asking ourselves, what in God's name are we doing when we were just slamming all of these people with opioids for their cervical radiculopathy or their lumbar radiculopathy from the waiting room? Um, so just to brief you all about what kind of a setup we have. So we're not like a tertiary academic center. We're a level 2 trauma center, but we have a huge amount of traumas every year. So 400 plus rib fractures, 550 hip fractures, and about a 20 to 30% admission rate from RER. So pretty high acuity. And we don't have an APS, and there's a very, very busy anesthesia department. They have time for some perioperative blocks, but not all of them. And then there's no real chronic pain management aside from palliative care, who will every once in a while dabble with some methadone. Um, so bundling, or what some people refer to DRG, if you're going to make a financial argument for making an acute pain service, this will kill any and all hopes of doing that. And the reason that I say that is because where we think about traditional billing from an outpatient perspective for the patients that we discharge, when patients get brought into the inpatient service, all of that money, that all the procedures get billed and they get bundled underneath of different codes. And essentially what that does is that the hospital ends up getting a kind of a lump sum reimbursement, which is usually somewhere at least a half, maybe a third lower than what was actually billed out. So, for example, here, if an ICU admission cost $110,000, was billed at $110,000, the actual reimbursement that the hospital may be at maybe $33,000. So, when you end up putting these nerve blocks in or these regional procedures in to the actual like financial argument that you're going to be placing, the actual amount that you're going to get back is usually dollars, not hundreds of dollars for it. So what I really did, the argument that I made is that for the most part, if you have a patient in the hospital, we know that a hip fracture, for example, you decrease their length of stay of hospitalization by doing an ER hip block of some sort, fasciolae block, PENG block, by about 0.9 days, because you're avoiding the opioid related side effects. They have earlier mobilization. And we know that just from a GMF perspective, a general medical floor perspective, that it's about $2,800 per day in Virginia, and this is published fairly widely. So by reducing their length of stay, we were able to basically show the hospital that, hey, by doing these on all of our patients from the ED, which I would start to consider standard of care at this point, as opposed to using high dose opioids, that we're decreasing hospital costs by over $1.4 million just for hip fractures. That doesn't include rib fractures. And then you can make the same argument for dislocated shoulders, rib fractures, decreased IUC length of stay, and improved respiratory mechanics. All of these things are patient-centered outcomes. So we really made that type of financial impact. So what do we do? We'll do almost any painful condition, whether it's traumatic or atraumatic. We do multimodal pain management for patients. We have a really, really robust OBS protocol when we've had some good success with rib fractures. And sometimes in collaboration with our palliative team, we will start patients on methadone, but this is usually for palliative issues. I'm not managing it, I'm not prescribing it or anything like that, but we help get them to a good level while they're in the hospital. And kind of the neat thing that we did is we wanted nothing to do with bringing the patients from the floors back to the emergency department. So because I think that that's actually the wrong thing to do for most patients who are in acute pain. So we actually take and we bring our team to the patient regardless of their location. And we actually do this by having a team of block nurses who will come and do it. So we can text them at any time of working hours. They'll come up with us. They'll hook the patient up to monitors. They'll document all of our medications that are given. And then they'll monitor the patients for 30 to 40 minutes after, depending on what block we do, whether it's a high volume block, low volume block. And this is complete cardiac monitoring, as well as vital signs. They'll also assist with it if we need it. So they'll push the meds for us if we need. So staffing is mostly me, but we also have I have a systems director and residency faculty and 2 fellows that also help do this. So as part of their training, they help and they actually take part in these blocks. So my position, this is what I do for a quarter of my time, and it's a quarter of my time is dedicated and paid for it on an hourly basis as a director for this, which includes doing the blocks, running the service line, and then if anything is up and above that, then I also bill for that as well. There are a lot of policies that went into this. We have a follow-up clinic, how to trigger the billing for inpatients, last protocols, how to make a consult process, equipment, anesthesia collaboration, Pyxis access, scheduling. All of these are things that are way beyond the scope of what I'll probably be able to talk today, but just know that there's a lot that went into this. And in the future, we hope to do a lot more iovera as well as catheter based. But we have some infrastructure issues that aren't allowing that at this point, but we are hoping to go there. So these are just a few of the cases that we've had that have been really good. So I had a 47-year-old who's actually a physician who broke his manubrium, had a retrosternal hematoma going around the aorta, and he also had 2 to 6 rib fractures. So we actually put this guy in OBS and we used Exparel on him. And we did an ESP block. And he had very, very good pain relief. He didn't require any opioids until about hospital post day 3. Didn't get readmitted, had no complications from it. We did this with trauma surgery, but he was in the hospital for less than 24 hours. So that was really, really a cool case. And then we had another guy here who he basically failed cardiac arrest because he failed extubation because he had a coronary artery perforation during cardiac cath, and he had a lot of right-sided rib pain. So we actually did an pectointercostal fascial plane block and a serratus anterior on him with a mixture of dexmedetomidine and ropivacaine, and he was extubated successfully by combining those 2 blocks. He had a good outcome, which is really good. And this is another one that I was really, happy with. Another cool thing that we're doing here, we did a 4-year-old male who had a mid-shaft femur fracture, and his mom didn't want any opioids because of drug history in the family. And so we just did an ultrasound guided femoral nerve block on him and had a really good outcome. So these are some of the cases, and this is the general idea of what we're doing. We do a lot of these inpatient, but we also do a lot of them in the ER. So I just want to open it up to any questions if anybody has any.
Super awesome. I do want to just really quick pivot to Dr. Vlasica, who also has a variation of this concept more from the academic side. So I'm going to let her kind of talk about her service that she also heads and operates. That way we can have kind of a multi-perspective view. And then we're going to dive into some more questions in about 5 minutes.
Hi, everyone. I'm Kat Vlasica. I am the Acute Pain Management Fellowship Director at St. Joseph's Health. And we kind of came about this from a different angle. All of my billing stuff actually just came from this need to, hey, I need a way to track these procedures. So, and our billers were pretty good. So I just unleashed them on it. So this kind of came more from an academic standpoint. We had this Alternatives to Opioids program that started off in the heroin capital of the tri-state area on the East Coast, so that worked out very well. And then we started just looking at more and more alternatives. So we started off with, okay, let's not give opioids to everybody who comes in through the door. Then we started with the landmark-based pain procedures, and then we started with nitrous oxide in the emergency department, and then we started doing regional. So this kind of evolved into more and more stackable skill sets that we needed to train. So that's how we started a fellowship, actually, is just to do all of these combinations of sports medicine and regional anesthesia procedures with a chance of addiction medicine and just an alternatives program that is being ran through the department. So with our regular ROIs and billing, we first started tracking this while we were hospital employees. And then about 2 years ago, we went into a private CMG group, and that's where our billing actually got very, very complicated because we now have separate codes and reports going for our professional fees and for our facility fees. And we run into slightly different problems than I think what Richard does. Our payer mix is very different. We have only 25% commercial insurance, and that's on a good day. And about 30% of our 45% of our insured are Medicaid. And then there's a significant chunk of our patients that have absolutely no insurance, and that's about 30%. So we don't get anything back on a massive chunk of our patients. So our argument was very similar to Richard's, as in, hey, we can improve outcomes and get patients out of the hospital very quickly. And that's sort of what got the buy-in for the fellowship and for the residency training. So we're running this more from a fellowship slash academic slash training side, just to prove that we have improved patient outcomes. And I do track our billing, but we're so far able to get more of the recoup on the professional fee side because we actually have different coders now than we do on the facility fee side, mainly because of the bundling issues that Richard mentioned. And I'm just going to stop yammering and leave it to questions.
Awesome. So I'm going to open the floor for both these wonderful folks to just kind of show you what they've done and how they've done it. And go ahead. Thank you, everyone.
Yeah,
Hi,
please.
everyone. I am Christine. I'm one of Dr. Vlastica's fellows, actually. So I'm doing something actually pretty similar to what you're doing, Richard, in terms of translating this into an inpatient consult service. I trained with Dr. Vlastica, learned from anesthesia, and did the fellowship. And then I was hired back by Cooper Hospital in Camden, New Jersey, where I am now working under the addiction medicine service. And so they hired me to do 0.5 FTE, just doing inpatient regional blocks for patients with opioid use disorder. We have a huge problem with the xylazine wounds. And so a lot of the patients that I'm blocking are for xylazine wound care, a lot of trauma. And my focus is really the substance use population because it sounds like similar to all hospitals, it's hard to get the acute pain service to get to the bedside and do these procedures. I run into a lot of issues with billing because I did not fully think about that when I started. Where I was hired under grant money. And so I think the hope was that I would bill more for, I'm billing correctly for my procedures, but what we're capturing is, like Dr. Vlasica says, about 20 to 30% of those charges. And so I'm definitely running into some challenges with my leadership in terms of really justifying like how I'm going to get funding to continue doing this service as well as expand. So it's just not myself. The one question I wanted to ask Richard is what's your volume of patients that you're able to block on a shift? Like, how did you streamline this? Because I'm running into the inpatient side. In the ED, I would get, with Dr. Blasco, we would do like 5, 6 blocks in a certain number of hours, and we could get a lot done because it was in a contained space almost. And now I'm running all around the hospital. And so I think I'm running into challenges on the inpatient side.
Are you talking about with volume? Like you're not getting enough volume or you have too much volume or?
Like I have a lot of patients who I'm requested to block, and it takes me a long time to, you know, I in the ED when we did our post-procedure monitoring, we would typically do 60 minutes. Now I like shorten that to 30 minutes because that's what anesthesia does at Cooper, which is within anesthesia guidelines, but it still takes like an hour, 30 minutes to an hour post-block for me to document, monitor the patient, make sure there's no complications. And then sometimes I'll be, across the hospital and I'll get a message from the nurse about some symptom the patient is experiencing. And it's a lot more technically challenging than I realized going into this, not being in one location. I don't know if you're running into similar issues.
No, so I mean, the answer is that it depends. I mean, I don't think that that you can predict when, somebody's going to put a whole bunch of soap in front of the nursing home, and and then you're going to have a whole bunch of hip fractures. But I would say that we average inpatient only. I'm not talking about like ED. So we'll do maybe about like 10 a week of like of these inpatients. And that depends. That fluxes like up and down. Like some weeks it's like ribs, and then like other weeks we end up having more of like acute exacerbations. The patient can't get out of bed. They need like a lumbar ESP or something like that. So what I've kind of leveraged and what I've done is I have set it for like 20 or 30 minutes, but our block nurses do all the monitoring. So what I basically do is I'll go out of the room, I'll leave the room, and I'll go and I'll do all my documentation. By the time I'm done with everything, consult note, medication recommendations, like all these other things. The patients for the most part been monitored, and they're done. And when I can, I try and stay away from higher volume blocks. So for example, like a patient who you do a ping on, they probably don't need 45 minutes of monitoring because it's a lower volume block, right? Um, especially if you're doing like a young and healthy person. Older people are a higher risk. So I really just try and streamline the process by utilizing our nurses, Pyxis access. If I'm going to do multiple inpatients, I draw up all my own medications. I can grab them out of the Pyxis myself, pre-draw them up, and that speeds things up a lot because like the consenting and drawing up meds, that takes up a huge amount of time. So those are some of the things that I've implemented.
Are you funded through the emergency department or through another inpatient service?
No. So this is actually funded through my the cost center of the emergency department. So the emergency department funds this. And the thought also being too that because it's going to be an ACGME requirement, probably sometime in the next couple of years, that nerve blocks are going to be part of core privilege of many emergency physicians and part of residency training. They're already coming out on the exams, actually. Is that we're going to need to leverage this and teach people, and so it's only a matter of time. Like the hospital recognizes it, and they also recognize that we have a gap. But I'd love to talk if there's other issues you're running into. I'd love to know more, talk more with you about it.
Yeah, it's interesting because I learned everything in the emergency department, and I'm realizing the inpatient side is a different challenge on its own.
Yes.
And then now I'm trying to think next steps. I'm jealous of your nurses because originally I think my leadership had anticipated, and me naively had anticipated, that I was going to self-fund myself. Like every block is $1,200. I'm going to be making so much money. And that's not been the case. So I think probably my next move will be to reach out to the emergency department, medicine, trauma, and see if they'll give me like funding for more FTE. Because if not, it's not realistic to grow based off of funding from blocks.
Yeah. So I actually did. I was really, really lucky. So we actually use our PIC nurses. Because our PIC nurses are constantly running around the hospital. So I actually got with our nursing CNO, and she was just like, "Oh, I know exactly who you need." And so they're very like they're not always able to go up there like immediately, but if I text them, usually within an hour, I can get up there. I can get up there and do the block with them, and they monitor them. So it's a lot less like workload on you, and they get appropriate vitals that are all put in. They can document all the medications. The thing that I think the thing that we don't that all of us don't understand about anesthesiologists, because my wife is one, and that's the reason that like I'm halfway like know any of this stuff, is like anesthesia does everything by themselves. They document their own meds, they pull their own meds. We're not accustomed to doing that. They do everything different than what we do. So I can't document the meds. I can pull them, but I can't document them. Yeah. So
Makes sense. I think Tom had a question.
Yeah, hey, thanks. Yeah, Kat and Richard, that's super fascinating and pretty cool. I'm just having a traumatic flashback to my N of 1 when I was consulted by medicine to do a scaling block on a hyponatremic patient that they discovered had a dislocated shoulder, and got my hand slapped by anesthesia. Two-part question. One, it sounds like you guys are like throughout the hospital system. Are you guys wandering around with your own cart-based machines, or how are you guys porting around ultrasound machines? And then question two, I wonder if you could just maybe shed some very brief light on what was your initial discussion with anesthesia, and how did you broach that topic to establish these services?
Yeah, so we're really lucky because we're pseudo academic emergency centers, so we have like 5 machines in the department. So I pull all of my meds from the Pyxis in the ED, which are they're actually already ordered under the patient, but I pull them in the ED Pyxis, and then I just grab whatever machine I want. I just bring it up there, and our workflow is such that I can actually order the point of care ultrasound, and I can document the image, and it crosses back over into QPath for us. So we have all of that. So I had to work with IT to do that. But it's really any machine that works. And then in terms of anesthesia, the big thing with them is that and I can't really go into too many issues just because it's like hospital level stuff, but anesthesia is, as I previously alluded to, was so busy, and it wasn't part of their contract because they're one of the only subcontractors in our hospital. It was not part of their contract to do inpatient pain, and because they could not do that, or it wasn't in their contract to do that, we had a sit down with them, and they're like, yeah, you want to do all the inpatient pain stuff? They allowed us to do all of it. They said they basically we made sure it was okay with them, they were good with it, and they signed off on us being able to do it, if that makes sense.
My interaction with anesthesia was that they don't get paid for the inpatient pain. So they're like, they don't want to do it. They don't want to be bothered with those patients. They're like, thank you, because now we are not going to get these phone calls. And they primarily make their money, through the outpatient procedures.
Yep. ASC outpatient. That's what they want because they get almost 100% reimbursement.
Nice.
Yep.
I have a question for you just regarding doing blocks on an inpatient service and having inpatient privileges. Did you run into, and forgive me because I missed the first 5 minutes, I was in another meeting. Did you run into any issues with your taxonomy? You are an EM boarded physician, and you ran across no issues with your taxonomy ID being affiliated with an EM specialty. You're allowed to bill for these procedures to the insurances without any issue. Okay.
Yeah, I haven't had any issue. The one that we did at the initial stages, there was some question as to whether or not the malpractice that we currently hold was going to be sufficient for doing these inpatient procedures. But after an extensive conversation with our carrier, they're like, actually, yes, like you're fine to do it because this doesn't happen in large emergency departments usually, but it's very common that EM physicians, especially some of our rural hospitals, they go upstairs, they do a central line, they do an intubation, they do whatever. And this is really, it's a pseudo elective, right? But it's still an emergency physician, like going up and doing something on a floor patient, which they were eventually like, okay, well, I guess that makes sense. And it is within the scope of your privileges. So go ahead. Yeah. I didn't have any issues with it.
Yeah, you didn't have to add any line items to your DOPs or anything like that. Okay.
No.
Good.
I mean, I could be, again, I'm just kind of like flying by the seat of my pants here for a lot of this. So eventually somebody's probably going to tell me something, but until they do.
Run right with it.
Yeah, right.
We had a question from Bob. How do y'all navigate not being able to provide 24-hour coverage, and how do you do scheduling?
Yeah, I would say that I'm in a really, really unique scenario in that I am only right now technically a quarter of an FTE to our emergency department. So a quarter of my FTE is residency, a quarter of it is fellowship, and a quarter of it is pain related services. So I do spend a lot of time, but what I end up doing is I essentially schedule the fellows for one day of the week. I have another core faculty member that I do have them do one day of the week, and then I'll end up doing 3 days of the week. So I don't do this on weekends. I'm doing this Monday through Friday during working hours. And the thought is that, most of the hip fractures, they're gonna end up getting, first case in the morning so that they can get repaired pretty quickly. But other things like rib fractures, they temporize them, and then we'll go in during working hours and do the block when we can. It's kind of similar to what anesthesia does for their APS. A lot of it's working hours. They don't come in unless there's like a problem with a pump overnight.
Yeah, I think also just doing single shot injections allows us not to be 24-hour. I talked to my anesthesiologist about doing a catheter-based service, and that the limitation is not having 24-hour coverage to monitor the catheters.
Yeah, absolutely.
Hi, this is Andrea. I'm at Hennepin. We do catheters here. I don't know if you can hear me. Can you hear me? We're
Yeah.
connected from the. I guess that would be my question, because I know in the future you're considering doing catheters, and if that's the case, what do you have a plan on how that would look? Because that's when we ran into a lot of trouble here, because we literally were just doing our own time, looking around shift schedule and ultrasound faculty being available, which was not sustainable.
That's a great question. And actually this is so I think I'm actually in a really ideal situation. And the reason I say that is because one of my wife's colleagues who works at a different hospital is very, very extensively trained in regional anesthesia. And we're actually planning on having an interdisciplinary service line that will actually do management of these types of things. So we're actually going to hopefully work together and give more availability for doing those types of procedures and to be able to troubleshoot should the need arise. But my general understanding is unless it's a very, very high critical need, that most of the time you can just turn the pumps off and you can troubleshoot it in the morning, unless there's something else that would say, hey, like you need to go on right now, like an epidural or something else along those lines. I don't ever want to do epidurals anyways.
Yeah, I think so. I think when it comes to it's lack of familiarity in the floor with pumps. At least that's what we've encountered here, and it's probably because we don't have a pain service other than the ultrasound folks in the ED, and anesthesia, similar to a lot of our shops, just manage OR or outpatient. And I think a lot of the questions that are told or get, it's related to a nursing or an inpatient medicine team not being familiarized with the pumps. And so that's when we decided to not go forward with it until we come up with a system that we can have a sustainable point person they can ask those questions.
Yes. My intention is that they're very likely in collaboration with anesthesia, because I think that there's some really good indications for these, which the best evidence that I know of, because we have a lot of amputations that occur from vascular disease. So there's a lot of evidence that these will prevent phantom limb pain. So we have a huge patient population of that. And then a lot of good evidence for rib fractures. So I think we would want to target particular patient populations, but we would also do it in collaboration with anesthesia. Like it's not something that I didn't get extensive training on these when I was in residency, which was now quite a while ago. But I think that there's room to do it. It's just I think it has to be done the right way.
All right, we are at the 30-minute mark, so I want to say thank you to all of our guests and all of the wonderful information we were able to get, the policies, the how-to. So I'm going to leave the recording to continue if there's other questions, but if you need to go, feel free to do so.